Hello everyone. As you know, we at AIM Canada are here to help you become licensed practicing dentists in Canada after your BDS or MDS. And it all starts with NDEB's step 1, that is the AFK exam. So, our topic of our discussion for today is Pulpal and Periapical diagnosis. Let us start with one or two questions that you may get in the exam. For instance, you can get a question. A 50-year-old female comes to your clinic presenting with pain due to hot fluids, and the pain is sharp and lingering. Another type of question that we may get is that the patient complains his or her tooth is off or elongated, and earlier the patient had pain in the very same tooth. It could be due to hot or cold. So how do you answer these types of questions? We have formulated a special table for you guys. This table will cover at least 10 to 15 of your endodontics and periodontics questions. So let's listen carefully. A patient comes to you. Let's look at the chief complaint. There is none. Pain on cold, hot or spontaneous. There is none again. Tenderness and percussion is not there. And radiographically, we do not have any findings. So, in this case, you do a vitality test and it is responsive to cold and responsive to heat. What is the diagnosis? Now, the problem here is a lot of children start going to tooth pulp necrosis, they go to other options, whereas it is just vital pulp. It's a vital tooth. Now, another example, patient complains of discomfort. They usually don't use the word pain here. Discomfort with cold or sweet. We have all seen these kinds of cases in our clinics, or during internship you must have seen at college. This pain is short duration, even to heat it's short duration. When you do the vitality tests, there is some pain but it stops. There is no spontaneous pain, no tenderness and percussion, and radiographically everything seems fine. This is a case of reversible pulpitis. So, short duration to cold or sweet, this is all reversible changes. Usually, the patient does not respond to heat. There is no pain to heat, right? So, this, if it is there also, it is just short duration. Coming to the third one, patient complains of sharp lingering. Lingering word is key here. They love this word, they tend to use it, or they may use a substitute like prolonged pain. To cold, heat, and what is key? There is spontaneous pain. Also, add here, there may be postural changes that lead to pain. Patient complains of pain on lying down. When you talk about cases of hot teeth, that's all in this one. This is irreversible pulpitis. When your patient says, I have started taking painkillers for this. When your patient says that my pain doesn't go for 15 minutes or it stays for an hour, it all goes towards irreversible. Coming to the next, there is no chief complaint. So see, this looks very similar to the first one. There is no pain to cold, there is no pain to heat. Now there is a star here because sometimes there may be due to C fibers. But there is no spontaneous pain, no tenderness and percussion. Radiographically everything looks perfect. But what you notice, this tooth is decayed. The first tooth there was no decay. In the first scenario, there was no decay over here. This is just necrosed pulp. This is a necrosed tooth. Again, we had an asterisk on radiograph because sometimes in irreversible pulpitis or necrosis, we may have some changes in the PDL. We may see some periodontal ligament space widening because of the crossover phenomena. It is going to cross over to the periapical phases, which we will come to later. Now, the next one. You remember the second question that we discussed? The patient felt that the tooth was elongated. This is an extruded tooth. So there is definitely tenderness on percussion, and mostly that is the chief complaint, that when the patient closes his or her mouth, there is pain on biting. This we also see in a vertical fracture case. So we don't have to be confused over here, because this is an elongated tooth which you do not see usually in a vertical fracture. Also in a vertical fracture you will see a J-shaped lesion, right, which we will not see over here. This is a case of an apical abscess. Now, why in an apical abscess there is no pain to cold or heat? Usually because most of the pulp is necrosed. I say most here, we have asterisks here because a little parts of pulp may still be there, may still be vital, and they may still lead to some pain on cold or heat or spontaneous. Therefore, the asterisks. Moving on to the next. This is really interesting, so let's pay attention on this one. The patient comes to us, there is no chief complaint, or there may be slight discomfort. No sensitivity to pain, to cold, or no pain to heat, no spontaneous pain. But what you notice is that there is a draining sinus or fistula. When there is a sinus or fistula, we know there is something chronic going on over here. And this is pulpal, this is not a periodontal thing. If you know that, you are going to go and check a radiograph. You see there is loss of lamina dura, or there is a periapical radiolucency. Now, if you notice that there is just widening of the PDL, you will call it chronic periradicular periodontitis. Whereas, if there is a periapical radiolucency, you will call it chronic periapical abscess. A lot of times they give you both the options. It is not about the right answer, it is about the best answer. Then, let's go to the next scenario. Patient complains of pain on or after biting. So a patient may say that usually when I eat food, after I release the bite, I have pain. Do you have pain to cold? Yes. Do you have pain to heat? The patient may say no. It gets relieved when I have something hot. Now this is an interesting concept. You don't see this with anything else. Pain is getting relieved when I'm having something hot. There is no spontaneous pain. Yes, there may be tenderness on percussion, and radiographically you do not find a change. This is not a vertical root fracture. This is a cracked tooth, which is so difficult to diagnose. So clinically they use transillumination, and you're going to go to the symptoms of the patient. That is how you come to this diagnosis. Last over here, this is also a very interesting one and very, very important for your AFK, because they want you to be able to differentiate this from an abscess. They want to avoid all unnecessary treatments. Now a patient comes to you, there is no caries, there is no history of caries, and then it's a mandibular incisor tooth. Probably there was calculus, you take an X-ray and you find that there is a periapical radiolucency. Sometimes it may also be a periapical radioopacity, but there is no pain on anything, whether it is cold exposure, heat exposure, or spontaneous. There is no tenderness on percussion, but the radiograph is showing you a lesion. It's a mandibular incisor. They usually tend to add the words black female with this because it's mostly seen in black women. Now what is your diagnosis? This is not a chronic periapical abscess. This is PCD, periapical cemental dysplasia. which starts as a radiolucency, it goes mixed, and then it may become a complete radio-opaque lesion. Now, one thing that we did not cover here is a very different kind of question that you may get. For instance, a patient comes to you and you check. This is your finding, the patient's lower molar, especially they talk about a lower molar, usually a 6, is decayed. It's a decayed tooth, and you take an X-ray and there is a radio-opaque lesion associated with one of the roots. And this radio-opacity may sometimes be outlined with a radiolucent area. And this is, my dear friends, condensing osteitis. I hope this clears a lot of your confusions, and this is helpful for you in your exam. Thank you, friends.